In the given case study, Mrs. Brown has a history of heart failure, a condition described as reduced contractility of left ventricle due to the myocardial tissue damage. This can be caused by various underlying problems, including myocardial infarction, ischemic heart disease, and hypertension. In the event of heart failure, cardiac output falls significantly due to the reduce in stroke volume. The stroke volume, defined as the volume of the blood pumped out by ventricle in each contraction. As a result, less blood will be ejected from left ventricle to the aorta in each contraction. When there is less oxygenated blood available for systemic circulation, there will be low blood pressure and it leads to negative impact in tissue perfusion mechanism. When baroreceptors located in carotid sinus and aortic arc detects low blood pressure, a compensatory mechanism will be activated to compensate low blood pressure and tissue perfusion. When sympathetic nervous system is stimulated by medulla, it expresses and secretes specific hormone called epinephrine and norepinephrine, causing stimulation of alpha-1 and beta-1 receptors located on blood vessel and myocardium respectively. Stimulation of alpha-1 receptors causes vasoconstriction of blood vessel, which influence both blood pressure and tissue perfusion. Stimulation of beta-1 receptors located on myocardium promotes force of contraction of the heart by enhancing calcium movement, but in the long run, excessive demand of contraction causes ventricular hypertrophy. Similarly, when norepinephrine binds to beta-1 receptors, it causes threshold to be reached more quickly. As a result, SI nodes fires electric signal more rapidly, and the normal heart responds by increasing its rate to stabilize cardiac output. But due to the functional and structural change in the left ventricle, patient with heart failure unable to balance between the pacemaker and the contraction, causing atrial fibrillation. When cardiac output falls significantly, there will be less oxygenated blood available, resulting reduced perfusion of kidneys, which stimulates renin-angiotensin-aldosterone mechanism. This compensatory mechanism releases renin from juxtaglomerular cell, an essential substance required in formation of angiotensin II. Angiotensin II is a strong vasoconstrict agent that increases stroke volume and arterial pressure as it increases afterload. On the other hand, angiotensin II is responsible in stimulating release of aldosterone and ATH by adrenal cortex and brain respectively. When combined stimulating action acts in kidneys, there will be retention of sodium and water, resulting increase in blood volume and cardiac workload. This action ultimately increases blood pressure as we see in Mrs. Brown's case. As the failing left ventricle is no longer able to pump out oxygenated blood efficiently for various reasons, including myocardial tissue damage, increase in preload, and overstretching of the heart wall. On a chest X-ray, the heart can be seen to be enlarged as a result of ventricular hypertrophy, a condition termed cardiomegaly. When ejection fraction falls 40% or less, residual blood starts accumulating from each contraction in the left ventricle. The normal ejection fraction of healthy heart is between 55 to 70% and calculated by stroke volume by end diastolic volume. Over the time, pulmonary circulation can no longer pass through the heart efficiently. This results in congestion of blood into the pulmonary vein, which increases the hydrostatic pressure within the pulmonary capillaries. As the pressure increases, congested blood then leaks into pulmonary interstitial fluids, causing pulmonary edema. Pulmonary edema thickens respiratory membrane, which alters the gas exchange process, and therefore Mrs. Brown is experiencing severe shortness of breath or dyspnea. In such event, bilateral basal cracker can be heard during auscultation of lung, as it makes harder for air to pass through the bronchioles into the alveolar and vice versa. It gets worse when the patient lies down because fluids spreads all over the surface of the lungs, which makes gas exchange process even harder. Therefore, patients with congested heart failure recommend to sleep in elevated bed or sit upright as much as possible to allow gas exchange as fluids goes down due to gravity. Recent study has suggested poor ventilation is the main contributor in developing hypoxemia as presented in Mrs. Brown case because it affects the gas diffusion process between air space in the lungs and bloodstream. Patients with heart failure often complain about tiredness, listlessness, and fatigue. Fatigue can be explained by the reduced perfusion of the skeletal muscle with oxygen and nutrient carrying blood. Feeling of tiredness can result from reduced perfusion of the brain. Such hypoperfusion sensed by chemoreceptors sends feedback to respiratory center to increase the rate and depth of the respiration.